Professor Stephan Langer from Germany. He is going to discuss a very interesting topic. Dr. Stephan is going to discuss long-term result after ultrasound-associated catheter-directed thrombolysis for acute iliofemoral thrombosis.
Yeah, thank you, Mr. Chairman. Thank you for the nice introduction. Thank you for me to being here again in your beautiful country. And my name is Langer, and I'm practicing in Witten, which is near Dortmund in Germany. So I would like to share our long-term results after ultrasound-accelerated catheter-directed thrombolysis in acute iliofemoral DVT. So here are my disclosures. So what are we talking about? We are talking about just a few patients you see per year in your unit, because proximal DVT is much more seldom than distal DVT, and I'm only talking about these patients. And normally the guidelines say we should treat them conservatively, but what is the patient's fate? They develop a very, very high level of post-thrombotic syndrome, and of these, 20% are severe. 5 years after the proximal DVT, nearly half of the patients develop a venous claudication, an underestimated pathology in my opinion. The risk of re-DVT is doubled. And why is it so? It's so because you all know that DVTs recanalize in the femoral popliteal segment in 90%. So we can put these patients on stockings. However, in the iliac segment, it only recanalizes in 20%. So these patients have a chronic remaining obstruction. And if you treat them conservatively, you put them on stockings and anticoagulants, but we know that compression socks are not in every patient better as placebo. So keeping this in mind, and we have some prospective randomized trials who made very good research on comparing catheter-directed thrombolysis with conservative therapy. Most of you all know these studies, the CAVENT study, the ATTRACT trial, and the CAVA trial. And the results of these three trials were inconsistent, especially when you look on the long term, and some of these studies only investigated for 12 or 24 months. So we have a lack of information about what happens in the long term, and it's really clear that a post-thrombotic syndrome needs lots of months or years to develop. So in the actual European guidelines, it is recommended that you can do thrombus early removal strategies in selected patients. But which patients are the best? So therefore, the aim of our study was to investigate the effect in the long term, and we investigated our patients we treated between 2011 and 2019. And this was a time where all these therapies, venous stents, Egyvasc, etc., came into the market. The study was done while we had the COVID-19 pandemic situation, and therefore we only had 22 patients in the follow-up. But first, these are the demographic data. Sorry for the German here. The median age was nearly 50 years, and this slide tells us that most of the patients had an unprovoked thrombosis, and above 20% had a recurrent DVT. So this is one example. This is a 36-year-old, very thin woman who suffered from an extensive iliofemoral thrombosis. Here you see in the angio relatively fresh DVT. Here the advancing of the catheter into the inferior cava. This is the result after 24 hours lysis, and here you see the underlying disease, the May-Turner syndrome, and here the result after stenting. You all know these slides. And here's another example, acute on chronic, an elderly woman. Here the lysis catheter inside, and here you see after lysis, and then you have to balloon it. And you see here some residual thrombus and the stents, dedicated venous stents. And you can achieve nice results. For example, here in this young patient, you see the severe swelling on the right side, and after 2 days, you have a normal leg. Okay, our early results. Normally, we use a popliteal access in prone position. We do it under local anesthesia, so the technical success is very high. The time is very long. We have a stenting rate about 45%, and since we use the Egyvasc since 2016, we use a lot of more stents, so this was a game changer. But let's come to the complications. It's not less, it's 24%, and I would like to focus on the major bleeding. These were 2 patients, and this is maybe a question for future research, but we had no PE and no mortality. Stop. Now it's hanging. Can you please help me? Okay, yeah. So now the aim of our study, the long-term results. The follow-up was nearly 4 years, a little more, and nearly 1/4 of the patient developed a post-thrombotic syndrome, but I would like to focus here, only 4% a severe post-thrombotic syndrome. The patency was quite good, 84%, and chronic venous insufficiency was, we saw in 63%, but only 22% in the higher levels. We investigated the life quality, and we could demonstrate that patients with severe PTS had, and this is expectable, had a worse life quality when compared to no PTS. Okay, taken together, we compared our patients to the interventional treatment group of the 3 great randomized trials, and as you can see here, we only treated proximal DVT. Of course, we had no control group, but this is very close to the CAVA trial, and we had our bleeding rate was very comparable to the CAVA trial, and the stenting rate was exactly the same, quite funny, and we had nearly the same post-thrombotic syndrome, so our results are very consistent with the CAVA trial, and I'm not really sure why these post-thrombotic syndrome rates are that high in the CAVENT and ATTRACT trial. But you can see here it's just 2 years, 2 years, 1 year, and we have 4 years and just 4% severe PTS. So taken together, let's come to the conclusions. Ultrasound accelerated CDT was associated with, in my opinion, good primary success and low complication rates. In the long term, we saw, in my opinion, low PTS rates, and it's definitely for the patients an improvement in life quality. However, we have, and this is the Achilles heel of the therapy, we have to reduce the bleeding complications and optimizing the procedure, and the opinion leaders are now doing aspiration, thrombectomy, and not lysis anymore. However, indication and patient selection, who is the right patient to undergo such an invasive procedure, is a question of future research. Thank you again for your attention.